Good morning. Welcome to Male Infertility Symposium 5. The title is Good Diagnosis Equal Excellent Management. My name is Hisanori Taniguchi from Kansai Medical University, Japan. Today we have 3 speakers. Each speaker will have 30 minutes, including a presentation and Q&A. There's no general discussion at the end of this session. So if you have any questions or comments, please write them at the end of each lecture. So let's move on to the first presentation. The first presenter is Professor Shiraishi from Yamaguchi University, Japan. The title is Good Endocrinological Evaluations Optimize the Maximum Outcome of Infertility Treatment. Professor Shiraishi, please start your lectures.
Thank you for your introduction. And I'm Koji Shiraishi from Yamaguchi University, Japan. So thank you very much for inviting me to present our work regarding to the endocrinological evaluations, which correspond to infertility treatment. I have no COI. So this is my overview of my presentation. So this is a very textbook figures indicating the hormonal regulation of the HPG axis. These red guides are LH, FSH, and testosterone and estradiol is a major player to evaluate normally our infertility clinical practice. So my question is, how estradiol regulates at the pituitary gland? It's a very unrevealed topic. Recently, there is a good review regarding explaining the regulation of hypothalamus and pituitary gonadotropes. It's reported by our university. So to explain the hormonal regulation, I reviewed the action of hormonal regulation of the LH and FSH and testosterone. They are very important to not only for infertility evaluation, but also very important from fetal stage. I don't describe this in detail today because it's a very, very basic topics. So now let's move on to the clinical practice. This is one of the infertility patients, but not for cancer patient. He has initially have oligospermia, but developed azoospermia within just 3 months. Within 3 months. So his endocrinical evaluation is like this, hypogonadism. In this situation, do you imagine this patient can have sperms? So it's a very curious situation. So it's not normal. So I imagine to take cranial MRI and shows that he has hypopituitary tumors. And the tumors treated by cranial surgery and radiologist. And he arrived. And he has a child with XT. So next case is this one, 28 years old oligospermia man. See this unique pattern of hormone. Hypogonadotype, very hypertestosterone. We can see this type of hormonal pattern. So in this case, I also immediately take CT scans and reveal that there is a retroperitoneal lymph node metastasis and reveals that he has testicular cancer. He has treated properly, and he's also alive. If this patient treated only same exam at gynecology department, he will be died. So this is a very simple textbook information. Normally, we evaluate infertile patients like this, hypergonadotropic or hypogonadotype. MHH is very easy to diagnose, but the most situation we can see every day is this one. Idiopathic case has normal LH or higher, FSH is normal or high, and testosterone is low to normal. So this is a simple and basic principle to evaluate male infertility. But as experts, we have to take more deeply understand this kind of endocrinological evaluations. So let's talk about the FSH level. The upper limit of FSH level is very different based on the companies. But the FSH level at 7.6 is used to evaluate to distinguish normal men from infertile men. This kind of this value is listed as the AUA guidelines. But some reports do not suggest the support the FH level is not useful. So like this, if the FH level have 7.6, based on their papers, this, we perhaps 20% of patients are not diagnosed as infertility, but this is our impression for our daily practice. So this is my friend, Brazilian friend. He has recently reported unique criteria to evaluate infertility patients called as Aphrodite criteria. I don't know why this is Aphrodite, but maybe he will know. So they classified the infertile patient group 1 to 5. Yesterday, Professor Peter Liu, he's not here, explained this deeply. I will introduce this criteria very briefly. For example, group 1 is male hypogonadism. And this Aphrodite criteria provides us not only infertility evaluation, but also provides proper hormonal management. This kind of criteria should be more deeply investigated. So currently, we don't have any deep evidence for regarding to the evaluation of endocrinological evaluation. So AUA guideline and EA guideline have a very weak or expert opinion level of endocrinological evaluation. But as usual, we have to, we think that the endocrinological evaluation is very important and essential evaluation for infertility patients. For Japanese guidelines, the endocrine evaluation is grade A and evidence 2. And for MHH, it should be a grade A and evidence 2. This should be also further investigated. So, and also, semen examination is a major player to evaluate the infertility patient. But hormonal evaluation support this. By combining FSH level and testosterone level, we can easily and exactly evaluate the infertility patient like this. Regarding to this paper, 15 million or below, or more. So this both T and H combination distinguish infertility patients were not very effectively. So interestingly, Dr. Kobayashi in Toho University, he's not here. So he has developed infertility evaluation without semen examination by using AI technique. But see this, FSH is a more strong power to evaluate infertility patient. So let's move on the endocrine treatment. There are many endocrinological treatment, like some like chloromethane and HCG and recombinant FSH and aromatase inhibitors. So there are so many, but time is limited. So I will explain some only, especially regarding to chloromethane. So this is my impression. Of course, male hypogonadism should be treated by gonadotropins. This is no doubt. And normal gonadotropin and higher gonadotropin, the evidence become very weak. So this is just a trial level. So let's review the mechanism of chloromethane. Chloromethane acts agonistically at estrogen receptor at hypothalamus. So brain judges, oops, estrogen is insufficient. So they increase GnRH and then increase LH and FSH and stimulate testicular spermatogenesis and testosterone production. What guidelines say? Our Japanese guideline just published 2024 recommend chloromethane is grade B. Oh, it is a mistake. A grade B recommendation But AUA some guidelines recommend grade C because of the lack of proper evidences. So under EAU, this is also the same with AUA. They suggest don't routinely do idiopathic cases regarding to SARMs and aromatase inhibitor, and also they refer about FSH treatment and also recommend a very weak recommendation. So this is a very interesting systematic review and meta-analysis regarding to the pharmacological and non-hormonal treatment options for male infertility. But I doubt chloromphene is non-hormonal treatment. I think this is the hormonal treatment. So this trail indicates the evidences. So as you can see here, evidences regarding to chloromphene versus placebo have many evidences. Let's see it. So in this figure, there are many figures in this paper. Regarding to sperm concentration, chloromphene versus aromatase inhibitor have chloromphene prefers. But regarding to sperm motility, that's very controversial. And this conclusion of this paper is that SARMs like chloromphene should not be used for infertility treatment. So this paper have a controversial standpoint to use chloromphene for male infertility. But this is also very controversial. There are many meta-analysis regarding to SARMs. This suggests the effectiveness of chloromphene to treat male infertility like this. Pregnancy rate will be better to use chloromphene, tamoxifen, and totally SARMs are recommended to use to treat male infertility. So another paper also suggests the same conclusion. This is listed as in AUA some guidelines. So they reviewed 16 studies and see improvement of sperm morphology, but not concentration and motility, and also preferable effects for pregnancy. So this paper suggests the recommendation to use chloromphene for male infertility, but it's expert opinion. How chloromphene was not used for a long time? There are many old studies regarding to chloromphene for male infertility. And this is a WHO study reported by Christina Wang, is a landmark study regarding to effectiveness of chloromphene. She concluded that chloromphene did not improve sperm motility and some concentration. How this happens? But after this study, recent report suggests the effectiveness of chloromphene. How this happens? It's simply an indication. The reason for the chloromphene action. Chloromphene should be used for men with normal or low testosterone patient. It should be. So this kind of reports includes a patient with normal testosterone patient. So our indication to use chloromphene is abnormal semen parameter and low gonadotropin like less than 4, and low testosterone less than 350, and administration is very weak. 5 milligrams 3 days per week, but not every day. So blood exam should be taken 3 months, and it should be taken maximally 6 months. So this is very complex. I used chloromphene for 131 patients, including control patient with no treatment. So sperm motility and pregnancy rate and no anti-pregnancy is significantly improved to use chloromphene. And multivariate analysis indicates that testosterone level is only the independent predictor to predict good pregnancy reproductive result. So see this, there is a significant difference between LH and FSH and testosterone. So this is significantly lower than the control, a non-pregnancy group. So chloromphene and including SARMs should be used for this patient. So But how many patients are included in our criteria? If we cut LH level 3.5 and testosterone level 350, only 8% of patients can be included in our criteria. It's a small group of patients. But in our clinical practice, I often use clomifene. It's a wider range, like LH at 4 and testosterone at 400. In this case, 26% of patients have included. So it's not negligible. So the indication of clomifene is very wider than we expected. So lastly, I'm gonna explain our challenge for non-obstructive azoospermia and aromatase. Yeah, because as you know, non-obstructive azoospermia often show hypergonadotropic conditions, which indicates that endocrinological ablation is strictly inhibited. But we are very challenging to treat them. So before that, I checked consecutive gonadotropin changes during the night. As you know, for control patient, gonadotropins are secreted about 1.5 or 2 hours cycles like this. This is our data, and LH and FH, there's a pulsatile secretion like this. But in case of NOA, they do have pulsatile secretion, but see the basal level. Basal level is so high, so if there is a pulsatile, but the effect of Leydig and serotonin cells is weakly stimulated. So that's the reason why I started to use high-dose gonadotropins to treat NOA patients, and actually they produce more testosterone. So I don't want to explain our salvage hormone therapy today, but in this case, we have sperm retrieval rate at 20% at second test. This is a hope for NOA patient who failed to retrieve sperm by microtest. So what happens in the testis? So we do want to know the hormonal circumstances in the testis. So in 2001, John Jarrow reported the percutaneous aspiration of intratesticular fluid to evaluate intratesticular hormonal environment. But in this method, only a few fluids could be obtained. It's not insufficient to evaluate hormonal status. So in our method, it's only for research purpose. When we do test or microtest, we have a little bit fluid, so we can quickly aspirate them and use centrifuge and use LC-MS to measure intratesticular testosterone called as ITT, and intratesticular estradiol called as ITE2. This method is very useful and repeated by a group of Taiwan. So they reported intratesticular steroidogenesis to use our method. So as a result, and as expected, the level of serum and testicular testosterone level is completely different as we expected. Intratesticular testosterone level is 120-fold increase, and there's no correlation between serum and testis. And also, estradiol is also 8,100-fold higher in testis, and there's no correlation between serum and testis. So what happened in testicular histology and after salvage hormonal therapy? After salvage hormonal therapy using high-dose gonadotropins, of course, there is a big difference, a big increase in intratesticular testosterone called as ITT. But one problem is the level is not correlated with sperm retrieval at second microtest. That's a problem. There is many complex mechanisms to regulate spermatogenesis. And also, let's look at the Redis cell morphology. By stimulating Redis cells using high-dose gonadotropins, there is no proliferation of Redis cells, but each Redis cells have increased their volumes. So they worked very well. So the next step we are thinking about is to use aromatase inhibitors to treat NOMM, because the information of aromatase inhibitor is very limited currently. But as shown here, there is some reports to support the effectiveness of aromatase inhibitor to treat infertile men, especially for obese men, and also Klinefelter syndrome, because they have a high, low TE2 ratio. So the protocol is like this. This is not a solid protocol. So, but where aromatase is expressed in our whole body, perhaps there is a much aromatase expression in lipid. But how about the testes? There is no report to investigate the localization of aromatases in testes. CYP19A1 is aromatase, as shown here. Aromatase expression in testes is mainly located in Redis cells. And also, interestingly, the expression is increased along with the deterioration of testicular histology. In case of SCO, the expression of aromatase is very, very strong in Redis cells. So we compared the testicular expression of aromatase and serum hormone levels. There is no correlation. But in case of intratesticular level, there is a significant correlation between aromatase expression and testosterone and E2, and also TE2 ratio. So if we can imagine or measure intratesticular hormonal status by non-invasively, it's a very good information. So this is 17-hydroxyprogesterone, 17-OHP. 17-OHP is reported to correlate with intratesticular testosterone like this. It is reported by 2008. And also, Dr. Ramasamy, I take a picture with yesterday with Dr. Ramasamy, and he has shown that using testosterone, it should be declined. But using HCG, 17-OHP is increased. That's a very beautiful result. And also, this paper is also reported by the group of Dr. Ramasamy. This is a very good paper using chloromphene and or HCG for 3 months. And see 17-OHP level divided by 15.5. So if the 17-OHP is lower in patients with have lower level, these kind of patients have good response to this kind of endocrine therapy, because basically this kind of patients have low ITT at first, and then this kind of endocrine therapy increases ITT. So this is very reasonable result. So there is another paper regarding to the effectiveness of 17-OHP. This paper uses recombinant FSH for infertility treatment. So like this, if the 17-OHP is lower, the FSH therapy is very effective. So the conclusion is that baseline 17-OHP less than 1.18 predicts the response. So by using this kind of new techniques, we can properly evaluate the infertility patient by endocrinological aspect. So this is another topic. So microtest is a gold standard to treat NOA patient, but there is no surrogate marker to predict the sperm retrieval. But many papers indicate the effectiveness of endocrine evaluation like this. So the most prevalent paper is FSH. Lower FSH will be a good marker for to predict sperm retrieval. And also, this is my unpublished data using transcriptome analysis using human testes. If stem cell transcriptome will exist, the FS level is lower. So we can see often many SCO patients after testicular biopsy or microtest, but they have some spermatogenic stem cells. Transcriptome analysis have shown that the existence of stem cells. So if they have, the hormonal therapy will be effective. So SCO patients have small hope to have sperms by endocrinological treatment. So this is I summarized my presentation. So previously, many papers have there are many papers, but each paper have no definitive parameters and no definitive endpoint. So there are many parameters for endocrinological assessment. We should focus on the certain endocrinological parameters and certain endpoint. So this kind of one-to-one investigation should be done in the future research. So in conclusion, good endocrinological diagnosis have excellent management for male infertility, but it sometimes detects life-threatening disorders, as I showed 2 cases of testicular cancers and hypothalamic cancers. So only semen exam have a risk to treat male infertility. So good endocrinological evaluations tell us proper selection of medical therapy and will give us many hints to develop future therapies for infertile men. Thank you for your attention.
Thank you, Professor Shiraishi, your wonderful presentation, including overview treatments, including clomiphene, aromatase, and adjuvant therapy of after the non-obstructive azoospermia. Is there any comments or questions from the audience? Please.
Thank you for thank you for the great information. Could you tell me the one question? If we patient get the sperm, ejaculated sperm by the salvage hormone therapy on NOA patient, so which is better to use ejaculated sperm or testicular sperm in the first ICSI?
Okay. So unfortunately, I did not experience ejaculated sperm for salvage hormonal therapy, but it's a very lucky patient. Patients do not want to do further microtest again, so it should be, the ejaculated sperm should be used. But in fact, there is no comparison using the efficacy of ejaculated sperm and testicular sperm. It should be further investigated. But I think the patient do not want to do further second test if he have ejaculated sperm.
Some patients get the ejaculated sperm once, but sometimes disappears. So it's very difficult to decide they get sperm. We should do the test immediately or later is better.
Yeah, if it depends on the patient's hope.
I think so. Thank you very much.
Thank you.
Thank you for great talk. I am Osaka Hiroaki Kitakaze in Osaka University. I have one question about you said that in NOA patients, lower FSH level can predict the SSR rate, high SSR rate, and you showed the data of stem cell transcriptome data. And how did you evaluate the stem cell transcriptome in testes?
Yeah, that's only under the investigation. That's information obtaining from the textile biopsy specimen. So if we transcriptional analysis for practical use is not possible. So as I shown in the immunohistochemistry, stem cell markers like c-KIT or something like that will be effective to find stem cells.
Okay, so
Okay.
you mean the not cell threshold only syndrome, but like maturation arrest
Yeah.
or some phenotype is more
Yes,
easy to
yes,
have a
yeah.
sperm.
SCO patient is not a truly SCO patient. If immunohistochemistry will be done, there are many stem cells in the in stem cell tubules.
Okay.
So I showed this as a Journal of Urology 2020 or something like that.
Okay. Thank you.
Please, this is the last one.
Thank you for this lecture. I will question about the anti-Mullerian hormone in male and fertility.
Yeah. Okay. It is a very big difference between male and female. AMH is very higher in fetal and very early period, but AMH lower level exists. But some papers support the usefulness of AMH to evaluate or to predict sperm retrieval for microdose, but it's very controversial, but it exists. Okay.
Thank you, Professor Shiraisi. Let's move on to the next presentation. The next presenter is Professor Dimitrios Gouris. The title is Genetic Assessment of Male Infertility. Please start your lecture.
Thank you very much. Good morning to all of you. We'll discuss a little bit about assessment of male infertility. I have to declare that I am a clinician. I'm an endocrinologist, so I'm not an expert in genetics. So I'm going to give you a clinician perspectives of how we are today concerning genetics. These are my conflict of interest. They are mainly academic and cannot be considered as a real conflict for today's lecture. I thought that a good idea would be to see what was happening in the past, what are the weapons we have today, and actually to have a glimpse to the future concerning genetics in male infertility. So what was happening in the past concerning the investigation of male infertility? Sometimes we perform only one test, and that was the spermiogram, or if you prefer, a series of spermiograms, in order to conclude to a diagnosis, or actually to what we consider it was a diagnosis. Actually, it was just a semen diagnosis, and according to this, azoospermia, oligoasthenoterospermia, normal sperm, we proceed to the management. But we know nowadays that things have changed, as we heard from Professor Shiraisi. The right way to do it is something like this. You need your clinical evaluation, so history and physical examination. You need your hormonal evaluation, always this will be done. A series of spermiograms, and of course it's not only spermiograms, it's seminal plasma, many other biomarkers that can be used, and imaging, an ultrasound. We are going to hear a little bit the next speaker about ultrasound. So I cannot imagine of a single case of male infertility that we wouldn't perform the basics, and the basics are this. On top of this, you may use histology, TESE, in order to see what's happening there, and some genetics, in order to arrive at a diagnosis that will be as much etiologic and not empirical it could be. And then, according to this etiological diagnosis, you have to treat your cause. So the management is going to be etiological as well. And this is how we are today. With the use of all these tools, we've managed to have an etiological diagnosis in about 2/3 of the cases, 66, 67% of the cases, it's not bad. But on the other hand, it still remains 1/3 of the cases that the male infertility is idiopathic. It is male, there is a deterioration in seminal parameters, but we do not know the reasons about it. So that was the past. What do we do now? Do we have some genetics weapons in our armamentarium? In order to make a long story short, I would briefly present these guidelines prepared by the European Academy of Andrology. I was involved in this. And concerning, these are the guidelines, they are graded according to the grade recommendation. So grade 1, strong recommendation, grade 2, suggestions, and then you have some crosses according to the quality of evidence. So these are the 21 recommendations. I focus in only one. So the European Academy of Andrology nowadays recommends karyotype analysis of the infertile men when the sperm concentration is less than 5 millions, yes, per ml. And the same is true for Y2 microdeletions. So perform them as far as the sperm concentration is once again less than 5 millions per ml. And you have to use cystic fibrosis transmembranase conductance regulator, CFTR gene evaluation, if you have a suspicion for incomplete congenital obstruction. So this is the short list of genetic evaluations that they can help you in order to establish your diagnosis. Karyotype, and with classic cytogenetic studies, and then with PCR, Y2 microdeletion, and cystic fibrosis. This is the karyotype. These are the Y2 microdeletions, so series of genes that they are involved, of course, in spermatogenesis, and cystic fibrosis with a broad phenotype, but we are interested in obstructive azoospermia or the congenital bilateral agenesis of the vas deferences. So once again, you expect to have some explanation, but still you have this 1/3 of the cases that you do not have an explanation. And you believe, this is your gut feeling, that the cause may be genetic because it's not varicocele, it's not an endocrine disease, it's not an infectious disease, so there is nothing else, more or less. It has to be something that has to do with genetics with one way. Still, we have some other tools nowadays, like the FIS, the fluorescence in situ hybridization, that you can use in order to determine some chromosome. This is a sperm prepared by these techniques, and as you can see, this is a 24XY disomy. So if this is combined with an ovum of X karyotype, you are going to have a Klinefelter syndrome. And this paper is already 15 years old, Human Reproduction 2010, that we have started to evaluate it, hundreds of candidates polymorphisms that could be associated with male infertility. So this is the present, and what about the future or the near future of, let's see if the future is already here. On top of the normal cytogenetics, the classical cytogenetics, the karyotype, we nowadays have already discussed the possibility of FIS. We now have the Sanger sequences for many decades, actually, so classic PCR studies. But on top of this, we have entered, once again, many years ago, the microarray era. So submicroscopic detection of submicroscopic deletion and duplication, or even SNPs, single nucleotide polymorphism, that they can give you some information about the cause of male infertility. On top of this, we have now a series of statistical, I would say, methods, so bioinformatics to be precise, so genotype-phenotype linkage, genetic association, GWAS study, polygenic risk scores, all of these are statistical approach to identify possible genotype, phenotype links. And they are already here with us and used usually by our basic scientists. On top of this, we have already reached the era of WES, of whole exome sequences. So you can have access to the whole genome. It's about 2%, the protein coding 0. So you can have data about this. And even you can have data about the whole genome sequences. So every gene that is on the DNA, every nucleotide sequence, independently if this is expressed or not. Do we need progression by the application, the appliance of these techniques in the clinical practice? Yes, for sure. This is a timeline, and you can see that in almost 80 years ago, we have only karyotype, and then we have PCR and Sanger. And now, as we discuss in the area of microarrays, and nowadays it's about 2 decades that we have the whole exome sequence. And look what's happening. Look at the exponential number of genes that we discover, and we know that they have some function they have to do with male infertility. Still not in the clinical practice, but they are there. And of course, the tool we are using for genetic analysis are more and more sophisticated. You can see that just 15 years ago, almost when we refer to genetic studies, this was just a single PCR, so Sanger sequencing. So you can see that more than 80% of genetic studies in male infertility back in 2010, it was PCR. But look what's happening now. Almost 50% is whole exome sequences. So it's very evident that we have a new era. I told about the future, but actually it's the present that we have these techniques. On top of this, we have valuable contribution by our basic scientists. So they are able to perform mutagenesis, so production technologies to produce mutations, specific mutation, and see what is happening in animal studies. So you can see a series of mutations that can be induced, and then we see specific phenotypes, what's happening in the sperm, in the testicular environment, and so on. And this is another tool to go forward. Let's go a little bit back to the clinical practice. Do we have now some genes that they are strongly, I would say, related to male infertility? The answer is an unequivocal yes. You can see series of studies. This is a very recent publication, 2-3 years ago. So these are genes that at least moderately linked to male infertility. Some of them are autosomal recessive. Some of them are autosomal dominant, X-linked and Y-linked. And you can see that they have been related to isolated infertility, syndromic infertility, endocrine disorders, as we heard, and so on. And this is, if you want, a more complete study of what we know now about genetics concerning the whole axis. So starting from abnormal hypothalamus and pituitary development and function, once again with this strong deep red, we have a definitive correlation between a gene and female infertility. With this orange, you have a strong relations, and with yellow, you have a moderate. So this is what's happening nowadays in genes at the upper level. This is what's happening in adrenal level. Professor Siraisi told us about 17-hydroxyprogesterone, abnormal development of the urethra or vas deferens, and then if we go to a microscopic level, I mean testicular level, genes that they are involved with Leydig cell dysfunction, certainly and only dysfunction, premeiotic arrest, postmeiotic arrest, spermiogenesis defect. Look how many genes are involved to spermiogenesis defect and even fertilization defect. But when we say, genetics, this is part of the story. Well, nowadays, publication is less than 12 months old, and it shows that a little more than 50% actually nowadays is genomics, so genetics. You can see a great deal of proteomics, so not just to have a mutation or a polymorphism of a gene, but to have problems with the expression of proteins, so proteomics, or small metabolites, so metabolomics. And you can see that they have a good share of the overall pie of the omics, and be sure that this part of the pie will expand and expand in the near future. So a short introduction to this, as I understand it, proteomics is the complete profiling of proteins, so expressed, present in a tissue or a cell, and with different techniques, you can detect more than 1,000 proteins in a sample. So once again, it's just not the genes, it's the proteins. And with these tools, you can decipher male reproduction. You can investigate proteins in the sperm, either the sperm surface or the subcellular proteomics, or you can go to the seminal plasma and look for proteins there, or the testicular environment in general and see some proteins there. And there is already good evidence that some of these biomarkers, I will define them as biomarkers, but it's proteins, can be used for varicocele, for unexplained and idiopathic infertility, for testicular cancer, for the sperm abnormality. So all the major questions, problems in modern andrology. And this is the evidence for this. For example, for varicocele, you can search for proteins in the sperm, like these proteins you can see here, and these are markers. You can see some details here. I will refer you to these publications about varicocele. You know, some of them are either indicative of bilateral or unilateral varicocele. So it's obvious that we move towards a new era. And the catalogs continue. Other biomarkers, proteomics, proteins for male infertility, unexplained male infertility, you can search for these proteins, and you can expect to have this type of results. Testicular cancer, you can search for proteins once and again, and you can see the different publication, and the catalog continues. Proteins specifically designed as biomarkers, discovered as biomarkers for azoospermia, for oligoasthenozoospermia, for globozoospermia, and so on. You have a little bit of everything. And it's not only this, it's metabolomics, as we discussed a little bit earlier. So this is one of the most recent omics. So it's after genomics or transcriptomics or even proteomics that we just discussed. And the aim here is to analyze the entire metabolome, so the final product of the metabolism in a system. So when we refer to metabolites, these are small molecules, usually less than 1 kilodalton. So you may have hormones there, you might have amino acids, you may have lipids, carbohydrates, you name it actually, that can be used. Once again, this is not exactly future, it's present. In a similar way to proteomics, you can use different metabolomics in sperm or in seminal plasma or in testicular environment. And once again, you hope that you will going to have indices about varicocele unexplained infertility. And this is once again some evidence, series of publications. Look what has been studied in which population, and these are the targeted metabolomics, and these are the main findings. We are able now to see different profiles in groups, or actually to classify men with infertility into subgroups while this was not the case in the past. We believe that it was just a group of men with infertility, but now we know that there are very different subtypes, subgroups of men, so you would expect once again to have more etiological approach. And once again, the list continues, different techniques, either in the blood or wherever, so you can find different set of metabolites. So what we did today is to discuss a little bit the past of approaching male infertility, always under the scope of genetics, what is happening now and what will happen in the future. So concerning the past, we said that with many decades now that we know that we may have an overview, a proper, a systematic diagnostic approach that would involve at least this, and more often than not these aspects, in order to arrive at an etiological diagnosis. We know that now what can be communicated to other clinicians, the catalog of genetic tests that we may use is still very small, and this is the catalog of what you can use without doubts over there. Although even there are doubts, there are different groups, opinion, approaches saying that, well, you must perform karyotype if the sperm is less than 1 million or less than 5 million or less than 10 million. There are publications this. Still, we have not decided even in this, let's say, old situation, let alone what's happening, what will happen in the future if we try to decipher, to understand all this valuable knowledge that we have today from our basic scientists. I think that including epiproteomics, proteomics, microRNAs, transcriptomics, we discussed some of this with you. I think we go to a bright new era for andrology. I'd like to thank very much the organizing committee for inviting me to this wonderful congress in this amazing city. And you have many regards from another amazing city that is Thessaloniki, Greece, my hometown. Thank you very much for your kind attention.
Thank you, Professor Goris, for your educational presentation. Is there any question or comment from the audience?
I have many questions. I do not have answers.
May I ask you?
Yes.
I think the important thing is genetic states will change the strategy of male infertility. And from the stand of this view, when do you recommend the genetic test for the patient with male infertility?
Yeah. Nowadays, you have to do it if you have certain indication. You cannot do all of this. They are very expensive, but the most important thing is that you do not have clear evidence how to use them. So, for example, if I know that patient X has a mutation in that gene, I know that this gene is related to spermatogenesis, but still I cannot use it in my clinical practice. So for today we are speaking, next year things may change actually. I will stay to the major issues as I told you. So karyotype for less than 5 millions per ml, YQ microdeletion is all these cases, expecting actually for a IGF-C microdeletion, usually in AGF-A and AGF-B microdeletions, the patients are azoospermic, have azoospermia, and then the CTFR in case you have a case of obstruction. If you think of a syndromic cause, then you may go for having that PCR for a specific gene that they will give you actually an answer. For example, in Greece, Eastern Mediterranean, we have a lot of congenital adrenal hyperplasia in both males and female. So it's worthwhile, actually, it's about, the carriers is about 8% of the population. So it's worthwhile if you expect a hyperandrogenemia in women or something is not going well in men to do it. So the basic investigation, plus very specific genes according to your clinical picture.
Thank you. Please.
Thank you very much, Professor, for your excellent talk. I'm Hatta from Malaysia. My question is more of a clinical aspect. As you know, as now the event of ICSI has actually revolutionized and increased the potentiality of parenthood to this kind of patients. And how do we want to counsel the patient thinking of that if we were to do ICSI and they have this kind of genetic problems, they would inherit it to their offsprings? Would that be a problem to us when we want to counsel them?
Yeah. Nowadays, thank you for this question. Nowadays, I do not have evidence to do something on top of this. There, of course, some of these will be inherited. Even the Y2 microdeletions will be inherited if you find some sperm and use it for ICSI. But if you think it more widely, this is true even in natural conception. If you have an intercourse with your wife, probably you have in your cells 150 bad mutation, and the same is true for your wife. These do not involve directly reproduction, they involve other features, actually. But still, you are going to have a child. So we cannot go directly to the other side, measuring everything or prohibiting, actually, things. Even, especially now that we do not have gene mechanics, I mean, to tailor genes, to cut them. So once again, I would do the basics, consulting. There is always a possibility of a genetics inheritance, and always would be there. If we manage to achieve reproduction, that's a good thing. And we may inform the patient that, well, you know, probably your son will have the same problem that you have, but if you have solved it in 2025, imagine your child in 2050 or 2055, we will have more weapons there. So we will try to increase our knowledge and to apply them wisely into clinical practice. Thank you.
Please, this is the last one.
Okay, thank you. My name is Gito from Indonesia. My first question is how many genes that you check for AZF? Because there's in one lab they check only 6, the other lab check 16, so it might be different.
Let me answer this and then go to the next one because I forget. So how many genes did you check? None. As we discussed, actually, I'll do the basic. I'll go to a gene only if I have clinical indication, but nowadays I cannot recommend, I know you are referring to this, there are panels of genes that you can use today, but I have no evidence to say that panel A that has these 6 genes comparing with panel B that they have these 16 genes is better than other. And once again, I cannot interpret the results. So I would be very cautious. It's still investigative tool. It's not clinical practice. And your second question?
Okay, on to the second question. If you know there's genetic causes, especially in zoospermia patients, how do you proceed to treat the patient? Because in Indonesia, we cannot do a sperm donor.
You mean if you have azoospermia?
Yeah.
If you have azoospermia and there is not a genetic cause, even if it is a genetic cause. In many countries, it's not allowed to have donor sperm for sure. You do not have many options. Of course, as we discussed with Professor Siraisi, there is a series of things that you can do. You can give HCG in order to increase the intratesticular testosterone, hoping for a better outcome in ICSI. You need a very good urologist to perform a good ICSI because there are always maybe foci of spermatogenesis. Actually, there are no good, as we discussed, indicators of finding or not sperm. We discussed inhibin B, we discussed anti-Müllerian hormone. And you may use, with some evidence, aromatase inhibitors, letrozole, SERMs, I mean. This is the only thing that you can do nowadays. Yeah. And FSH, of course, you may use FSH if FSH is not already high.
Okay, but if there is a genetic cause, what can you do?
there is nothing you can do. If you find a genetic cause that you know that is a gene involved in spermatogenesis, then this is the case. You found the reason, but cannot treat it yet.
So thank you, Professor Goris.
Thank you very much.
Let's move on to the last presenter. The last one is Mr. Shoichi Nariyoshi from Japan. The title is U.S. Imaging in Male Infertility. Please start your lecture.
My name is Shoichi Nariyoshi, a medical laboratory technician and sonographer. First of all, it's a great honor for me to speak at this wonderful meeting. And I would like to thank the professors who recommended me. Also, my English is not fluent. Sorry. I am confident in my ultrasound US skills and would like to share my experience. Let me begin. I have no financial disclosures. At our clinic, we perform US high frequency transducer 10 megahertz on a patient during their initial consultation for male infertility. For this presentation, we will focus on 2,395 cases from July 2020 to December 2024. However, I have personally performed the US examination on over 60,000 patients to date. And I will share insight our broader experience as well. US is used calculation testicular volume and observe varicocele. Internal structures, reproductive tract, and predict sperm retrieval success in case of non-obstructive azoospermia. Calculation of testicular volume. Grayscale images of the testes are obtained in both transverse and longitudinal planes. Testicular length, weight, and height are measured using electronic calipers. The largest measurement in each dimension is used to calculate testicular volume using the Lambert formula. Varicocele detection via US. Varicocele is diagnosed through physical examination and confirmed by US findings, such as venous dilation and reflex signals. At our clinic, we also measure the reflex signal and diameter of the caudal vein. Sorry. The overall improvement rate was about 70%, while in patients with bilateral caudal vein dilation, the improvement rate increased to 83%. This indicates that US findings, particularly caudal vein dilation, can be predictive of treatment outcomes. Detection of internal testicular abnormalities. US image of the testicular cancer. US shows a solid mass with blood flow detected by power Doppler. Since male infertility patients have a higher risk of testicular cancer, we routinely perform Doppler US. US image of inflammatory regions. US revealed a solid mass without blood flow on Doppler. After 6 weeks of antibiotic treatment, the mass disappeared, confirming inflammation rather than malignancies. US image of the testicular cyst. Around an echoic area was observed consistent with a cyst. Summary of findings. There were 3 cases of testicular tumors, 6 cases of suspected tumors, 4 cases of inflammatory, 10 cases of cysts. In case of testicular tumors or suspected tumors, few cases could be detected by palpation. Even small testicular tumors can be diagnosed using US, which is valuable for subsequent monitoring. We perform Doppler US to detect testicular cancer with tumors identified in 0.1% of cases. Male infertility patients are at higher risk for testicular cancer, and US has been useful in diagnosing non-palpable testicular tumors. US images of testicular microlithasis, TM. TM appears as punctate hyperechoic foci within the testis on US and cannot be diagnosed by palpation. TM was found in 6% of our patients. In patients with less than 5 TM, 49% had poor semen parameters. In those with more than 5 TM, 36% had poor semen parameters. In azoospermia cases with severe TM, diffuse calcification was seen. All 6 patients with severe TM underwent microtessay for treatment of azoospermia, and the sperm retrieval rate was 100%. Microscopic findings of the testis and the specimen. Many small shiny granular materials and spermatozoa were observed. Microscopically layered calcifications were observed in every seminiferous tube tissue. TM was found in 6% of cases and only detectable via US, and may be linked to spermatogenic dysfunction. It is also associated with testicular cancer in 0.8, 9.5% of infertile men. Severe TM is NOA patient suggests microobstruction in seminiferous tubes and may predict successful sperm retrieval. Evaluation of the reproductive tract with US. Azoospermia is classified into obstructive OA and non-obstructive NOA, with differing sperm retrieval outcomes. We use scrotal and transrectal US to assess it. In evaluating the reproductive tract, we use scrotal US to examine the lead testis, epididymis, and vas deferens, while transrectal US assesses the urethral segment of the vas deferens, seminal vascle, and ejaculatory ducts. Findings in OA. US image of the lead testis. Normally, the lead testis appears as a triangular hyperechoic structure on US. When the lead testis is dilated, the affected area appears hyperechoic. Epididymis. The epididymis is adjacent to the testis and appears elongated and hyperechoic on US. If there is a defect in the epididymis, it appears as an interrupted hyperechoic area. When the epididymal duct is dilated, The dilated portion appears anechoic on US. The birth difference is visualized as a hypoechoic muscle layer with a hypoechoic double line along the luminal wall and the hypoechoic lumen. When the lumen dilates, the anechoic areas also demonstrate significant dilation. Transrectal US reveals the spermatic tract and any obstruction. The ampulla of the vas deferens and seminal vascule appear hypoechoic. And are continuous with the ejaculatory ducts in the prostate region. This image shows significant anechoic dilation of the ampulla of the vas deferens caused by calcification of the ejaculatory duct. Therefore, TESE was selected as a treatment approach. This image, in which the ampulla of the vas deferens and seminal vascule are not visible, is critical findings, suggesting congenital absence of the vas deferens diagnosed during the initial consultation. This significantly increases the likelihood of successful sperm retrieval by TESE. If the preoperative diagnosis is OA, conventional TESE is performed. OA is diagnosed when US shows bilateral obstruction of the reproductive tract, and if FSH levels are normal, the sperm retrieval rate approaches nearly 100%. US image of the NOA. At our clinic, we also perform US for predicting sperm retrieval in NOA. Micro-TESE involves identifying thick opaque seminiferous tubules, where sperm are more likely to be found. The sperm retrieval rate is about 40%, but preoperative prediction is difficult. We confirmed that normal seminiferous tubules appear hypoechoic when visualized using the water immersion method. When the harvested tissue is placed in culture media, the seminiferous tubules also appear hyperechoic. Grayscale images from Luchin, US, showed no difference in introtesticular echogenicity between patients with OA and those with no NOA, except for testicular size. We also evaluate seminiferous tubes diameter using a unique method involving adjustment of brightness and contrast in US images. Unprocessed and processed grayscale US images in patients with OA and NOA. Top row. Unprocessed images. Middle row. First step, processed images. Bottom row. Second step, processed images. Bands of seminiferous tubes became visible in case 1 OA and case 3 NOA. No tube bands were observed in case 2 NOA. This is actual cases. Crop the image. Large. Set contrast to 96%. Set brightness to 50%. Then reduce brightness to 30%. Six seminiferous tubes with a diameter of 300 micrometer or more were observed at the upper part of the testis. Microtessay was performed and sperm was successfully retrieved. This is with only thin tubes. Set contrast to 96%. Set brightness to 50%. Then reduce brightness to 30%. The testis contained thin seminiferous tubes with a diameter of approximately 200 micrometer. Microtest was performed, but no sperm were retrieved. We classified seminiferous tube diameter by first visualized image into 0, invisible, 100, very thin, 200, thin, 250, thick, and 300, clearly thick. The general sperm retrieval rate for NOA is 30%. But sperm retrieval rate increased to 63% when using this method, showing its value for pre-surgical planning. ROC curve analysis for FSH, testicular volume, seminiferous tubes for sperm retrieval in microtesserae. The AUC were 0.61 for FSH, 0.59 for testicular volume, and 0.82 for seminiferous tubes. If US shows obstruction in both ducts and FSH is not elevated, OA is diagnosed and sperm recovery is nearly 100%. Even in NOA, seminiferous tubes with a diameter of 250 micrometer or more seen on US suggest a higher chance of successful sperm retrieval. US is essential evaluating male infertility. It is useful for diagnosing the cause of infertility, identifying comorbid conditions, and predicting treatment outcomes such as sperm retrieval success. I hope to continue providing useful US findings for clinical practice. Thank you for your attention.
Thank you, Dr. Nariyoshi. Is there any question or comment from the audience? Yes, please.
Thank you very much for the wonderful presentation. I'm Panagiotta Tsunapi from Infertility Clinic from Yonago, Japan. I would like to ask you, once you find the OA, the obstructive azoospermia, and you see the obstruction in the vas deferens, you suggest TESE. How about epididymal sperm aspiration? In which cases, do you always go for TESE, or you also suggest to the patient the epididymal sperm aspiration?
Always perfect obstruction.
I'm sorry, one second, I couldn't.
Do you recommend the TESE or aspiration from the epididymis?
TESE.
Yeah.
TESE?
In OA patients, in obstructive musculation.
And epididymis inspiration.
Yeah. Okay. So both. Which are the selection criteria, for example, to separate that this patient is better to have TESE or like, of course, the testicular sperm is the best. I mean, as an environment, is more protected. It's not so much like the oxidative stress to be exposed to as in other tissues. But it's less invasive, I mean, the aspiration, that's why.
Now we are taking both because sometimes the testicular sperm is more better than epididymis. And we are now doing both.
Thank you.
Please, this is the last one.
My name is Kosuke Kojo from Tsukuba University. Thank you for your wonderful presentation. I have one question. Have you ever followed up the patient with hypogonadism and who who take the replacement therapy, and they will change the testis examination, right?
MHH.
MHH. Yes.
Follow-up experience. Please, changes intratesticular seminiferous tubes.
Okay. Can you distinguish the change, the spermatogenesis of testis through the ultrasound examination?
I think this is a very rare case. However, check the before and after the hormone therapy.